just to let us know your affiliation. It's nice to know each time. Before I introduce our speaker for today, just a reminder that we still have translated captions. And so if you're interested in having translated captions in a language other than English, that is available to you. And I will put the instructions in the chat, but you can also go to captions and enable the translation. As long as you select the speaking language as English, it should translate from whatever Mritika is saying into the language of your choice. And so that is available to you today. You will also see if you leave the meeting today, we will have an evaluation survey pop up immediately on your browser. And please take that very, very short survey just to provide feedback on today's session and on the lecture series in general. And I will also post information about that in the chat. This is our second session in the weekly IR Connect lecture series, and we're so happy to have with us today Dr. Mritika Barua. Mritika is an assistant professor and deputy director of the Center for Science of Implementation and Scale-Up at the Brack James P. Grant School of Public Health at Brack University in Bangladesh. She's a mixed methods researcher who has more than 10 years of experience in public health, broadly in infectious diseases, climate change, sexual and reproductive health, and implementation research in Bangladesh. And I'll let Mritika introduce herself further if she likes, but today we'll be talking about implementation strategies, identification, and adaptation. And this will really build on the lecture that we heard last week from Dr. Piyusha Majumdar, who talked largely about the importance of context. And so now we'll be moving on into talking about identifying and adapting strategies. And so with that, over to you, Mritika, and thank you again for joining us today as part of this weekly lecture series.
Hi. Hello, everyone. Am I audible?
Yes, we can hear you.
Okay. Thank you so much, Anna, firstly, for inviting me to this lecture series. It's really a pleasure to be here, to be part of a crowd interested in implementation research. For me, although it is a lecture, but I think for me, I would really like to make it more like a discussion. I'm sure there are many of you here who have probably more experience in implementation research than I do. So it would be great to hear your examples at the end of the presentation. So I think Anna said it all from my bios that are everywhere on LinkedIn and other research profiles. There isn't much to add, except that although I'm a mixed method researcher, I'm more inclined towards qualitative research and participatory methods. That's also something that I like to use in my research, especially also implementation research, like a lot of qualitative research methods. It's really nice to also see that many of the people that I know as a student or as a colleague and has joined today's lecture. So thank you for joining. So the lecture isn't much big, but I would like to take questions in the end, and I hope that's okay with everyone, because, you know, as it happens that as the presentation goes on, many of our questions also get sort of like answered, and it would be nice if we just take questions at the end, then we can have more fruitful discussion based on, you know, what has been said so far. And like I said, I would love to hear your examples. As you know, the topic for today's talk is implementation strategies, identification, and adaptation. So in between my talk, I will give examples from two research from our Center for Science of Implementation and Scale Up, where we did implementation research, and I'm going to give examples of some of the strategies of the, you know, those interventions and what are the adaptations that were made, and hopefully that will, you know, help you to connect. Okay. say. I can go to the next slide. Sorry, just bear with me. Okay. Okay, so what I'm going to do is I'm going to talk about evidence-supported implementation strategies. How do we identify them? How can we use them to address some of the barriers? And I'm going to also talk about some of the concepts that we come across when we think about adaptation, when we think about fidelity. And I'm also going to deduce some framework and approaches that we can use when we want to, explore adaptations, or, when we want to research adaptations. I think in the last lecture, you do have a sense from the last lecture that Dr. Pirsha gave, you do have a sense of what are evidence-supported implementation, interventions, evidence-informed interventions. So these are basically what is it that we're trying to implement. So what is the intervention? And intervention is implemented to achieve certain, outcome, like improved health outcome, for example. So what is it that we are trying to implement? And how we're implementing it, the process and the steps, that's implementation strategy. So basically, how do we reach that intervention? What is the process by which we are implementing that intervention? And it's very important to understand the difference between what we are implementing and how we're implementing, because that really forms the backbone of distinguishing what is it, what are implementation strategies, and how they differ from the intervention that's going to be implemented. So evidence-informed interventions are basically programs, what practices, the procedures, or, some kind of product is given. Some of the policies have been, formulated and implemented. So basically, these are the different types of interventions that we come across that are implemented to improve health behaviors, health outcomes, or, like to improve health-related environments. Whereas implementation strategies are like the technique or the methods that the that the implementers, or like a certain team, they use to support the adoption, the integration, the spread, and the sustainability of the intervention in practice. So basically, is a technique that we use to implement the intervention, which ensures that the intervention is uptaken by our client or the beneficiaries or whoever the intervention is meant for, that the intervention is integrated into the current practices because it's meant to improve a certain outcome. The intervention is also the idea that intervention has a certain coverage, it is spread out, and it is also sustainable. So strategies are the techniques that ensures all of these components that I just spoke about. And implementation strategies also target determinants at several levels. There are implementation strategies that can target the individual level, the community level, the organizational level, and the system level. And implementation strategy can be like a single strategy, or can be like a build-up of a couple of single strategy into multiple strategies. So whatever strategy that we take, the ultimate goal is we want to address some kind of barrier to make sure that the service is taken or the intervention is taken. So the different levels that I talked about. So ecological model is very useful to understand. It's a framework that can really help us to understand the multiple levels which can play a role in acting as a facilitator or acting as a barrier to certain implementation. So if we look at the individual level, it could be the knowledge of the people about a certain service, about a certain disease or certain outcome. It could be the attitude of the people, it could be their health-seeking behavior that can really affect, whether they are going to uptake certain services. Similarly, there is interpersonal level where social networks, relationships, their important friends, how they are also aware of those services, what is their health-seeking behavior, for example, what is the current practice in that network regarding, certain issue. And then there's also community, which is bit wider, that has both interpersonal and individual level. In the community also, like you see, what is the community practice, what are the different relationship between stakeholders. Then there is organizational level, where organizations themselves have their own policies, their norms, their practices, the way they do things. Then there is also overall, that whole environment of like policy, what are some of the laws that can really act as a barrier or a facilitator for certain implementation. So this model is actually quite useful in identifying some of those, barriers and facilitators at each level. And it's important to go through each of these levels, because understanding these levels, understanding the barriers and facilitators at each of these levels would really help us to design our implementation strategy. So there is a very important paper. It's based on ERIC research. So ERIC is expert recommendations for implementing change, because there's so much of implementation science related papers out there, publications out there, and there are so many research that have been done that talk about many different strategies. And what ERIC did, the group of people, the ones who were leading the study, they brought in several experts in implementation research and implementation science, and they identified 73 discrete implementation strategies mentioned in the literature, and they defined each of those strategies, and they actually clustered those strategies into 9 thematic clusters, which I'm going to show in the next slide. This paper, this research really gives us a very good idea about what are the different types of implementation strategies that could be there, which would really help us to understand, based on this paper, what are some of the strategies, how those strategies have been defined, and if we're thinking of an intervention, where does the strategies that we're thinking fit within those clusters. So this paper is actually quite interesting, and I think it's very useful also to understand, because the idea is that it's not just one single strategy that can have an impact, but it's just an amalgamation or like a combination of. Okay, so sorry if this is a repetition for those who have already heard me talk about it. So basically, through the ERIC study, what the authors did, they brought in a couple of experts who are experts in implementation research, and they went through the vast amount of literature that exists on implementation science and research, and they identified 73 discrete implementation strategies. They defined them and they clustered them. And this paper is very useful because it gives us a sense of, when we're thinking about implementation strategy, in which cluster does that fall into? Because under each of those clusters, as you can see in the next slide, if you look at the left column of the table, under each of these clusters, they have a list of strategies, listed in the paper. And it really gives us a sense of, if we're talking about how to engage consumers, for example, what are the strategies that others have done? The strategy, for example, that you're thinking of, does that fit within the cluster, or does it fit into somewhere else? So if you have time, I would say you go through that paper. It really gives a very, very nice, vast, like a snapshot of, the implementation strategies that have been, that is out there, and how they have actually defined them. So, for example, in terms of engage consumers in the thematic area, one of the strategy from the paper is you involve the consumers or the family members, because if you want to engage consumers, you have to make sure that they're also involved. Or, for example, if you want to train and educate stakeholders, that's what implementation strategy is. You want to train health workers. So what cluster does that fall into? Train and educate health stakeholders. And what strategy does that say? Conduct ongoing training. So this paper just gives like a very, very good idea, I would say, like in a very short few pages. So when we're thinking of an implementation strategy, it's important that we answer some of the questions that helps us to understand the strategy. So, for example, naming the strategy, defining it, Then specifying it, like who is the actor, who is going to implement that strategy, what is it that they're going to do, who is the strategy meant for, when is that strategy meant to be implemented, like, at what time of the month or year or when, like in what dose. So for example, is it over a couple of weeks, over a couple of months, hours? Then also think about how can you measure the implementation outcome. So, implementing the strategy, what outcome you're expecting, and how would you measure that, whether that strategy has led to that outcome, and what is the justification of, having this strategy, as a part of your implementation. So once we define the strategy like this, it gives us a very clear idea about, what is it that we are actually looking for. So when we think about adaptation, it's like we have an intervention and we have a series of intervention strategies. And oftentimes, even though we design an intervention and we list a series of strategies we think that would really lead to a certain outcome, but oftentimes we see that because of the contextual barriers, because of, certain maybe study population or target population, or maybe some other factors, that we have to adapt it. Maybe the intervention was, implemented in a different context. If I want to apply it in my context, so what is that adaptation that I need to make? Do I need to make any cultural adaptations, any language adaptations, or do I have to bring in certain stakeholders that were not there in that context, for example? So when we think about adaptation is really a thoughtful, deliberative process. Like, like you have an idea beforehand, for example, in most cases, like why you want to adapt that particular strategy. So it's thoughtful, it's deliberate. So you're making changes to the design, maybe you're making changes to the way that it's going to be delivered, ultimately with a purpose that your goal is to improve its fit within that context, because you want to have a best fit of that intervention in that context. So this is what adaptation is. It's a process of that change to that design or delivery, in the hope that it would improve that fit. And in order to understand adaptations, it's also important to understand, when, like what you're adapting, like how you're adapting, and when is it that you need to adapt, because understanding is very vital, as implementing the intervention is quite dynamic. So for example, I mean, when you're adapting, there has to be a very good rationale for that, because if you feel that adaptation can, bring to an improved outcome, bring to an improved function, or like more successful intervention, so which means that adaptation can, lead to maybe more engagement within the users. There's more acceptability in that community, and maybe the clinical outcome is better. So when we're adapting, it's important that we retain the key elements of an intervention, the core elements of an intervention, without which the intervention will not be effective. So if we fail to align the modification within our population needs, then the intervention is not going to be effective. Similarly, we also need to keep in mind how we are reporting that adaptation, because if the reporting is not consistent, it can also, like, there is no way to know whether that adaptation has led to that certain outcome, and what type of modification has actually led to that success, for example, we wouldn't know, because this information would be relevant when we are trying to scale up that intervention, for example. So just to give you a very quick example from one of the implementation research I was part of, it was a research funded by NFPA, and we did it in the Rohingya refugee context in Bangladesh. So Rohingya refugees are, the Myanmar nationals who fled due to the conflict, and they are in Cox's Bazar, which is, near the coastal region of Bangladesh. So in the Rohingya refugee population, if you look at the context, the providers or the implementers, they realized that that the Rohingya women, the pregnant women, they were not attending the facilities to give birth. They were not coming to the facilities as much as they should be, not coming for the ANC or PNC, or not coming for, to deliver. So what they did is they introduced intervention, which they call the referral system, and in that they have like a referral hub, which is like a like a structure, and they introduce a transportation system because one of the delays for maternal delay in seeking maternal care is one of the delays actually transport. So the main problem with Rohingya refugee context is those temporary settlements, they're on hills and the roads are not good, which means that good transport system is not there. If you have to go to the facility, you might have to walk very long distance and then take a public transport and then go to the facility. So what they did is they introduced a vehicle, a free transport vehicle, and their idea was that the pregnant women, they will use this vehicle and they would go to those facilities, give birth, and afterwards, like it's a pickup and drop service. So their strategy is that they involved community health volunteers, which were male, and they did household visits. And during household visits, they were collecting details about pregnancy, from those women, and at the same time they were sharing the hotline numbers of the referral hub. So the idea was that if they needed the transport, if they needed the transfer to the facility, they would give like a phone call to the referral hub, and then the car will come and pick them up. So that was the idea. So what the community health volunteers did, they took those details of the pregnant women and when is their expected date of delivery, and then they would share also the hotline numbers of the referral hub. Then when there is a need for transport, it's either the patient or the family they calls, or even can walk to the referral hub and inform of the need for transport. Then the community health volunteer went to the community and brought the patient back to the referral hub, where in the hub the emergency was assessed. It was assessed whether it's like a primary care, that could be provided by the paramedic. Maybe the woman was not ready to give birth yet, whether it was really an emergency or not. So those kind of assessment went on at the referral hub. And then if the patient needed to go to the hospital, the patient was taken to the primary health care or just tertiary hospital, depending on the emergency, and then dropped back afterwards. So when we did the research, we identified several barriers, and at the same time, we also identified some of the adaptations they made while they were implementing this. So, for example, one of the adaptations they made was that the community health volunteers were not only sharing the hotline number. So what they did previously was there was a maternal card where they had the names of the mothers and what duration of pregnancy she was in, and then there would be like a number of the hotline. What they did later on, they adapted. They actually wrote those hotline numbers on the walls of their houses, and also another adaptation they made was that the patient was not brought to the referral hub to assess their emergency. What they did was, after the phone call, the community health volunteers went to the patient's house, assessed the emergency at the household of the patient, called the driver of the vehicle to come as close as possible, and they would carry the patient on the stretcher or like a wheelchair and then take to the facility. And after our research also, what we found in our research as well, that the Rohingya women didn't want to use the vehicle because one of the primary reasons that came out was that they didn't want to share pregnancy details with community health volunteers were male. Because if you look at the context of the Rohingya women, there are very social, strict gender norms, and they do not want to talk to men outside their families. So, which is why also one of the reasons why they didn't want to be in the same vehicle, because it was a mixed gender space, because they were only men. There were no other female members present in the vehicle. So we found those to be like one of the significant barriers. And after our research, what they did was they deployed community health workers instead of male to collect pregnancy details of the women. So this is just some of the pictures. So on the left, you can see the referral hub they had where they were bringing the patient, and on the right is the transport that they were offering, free transport. Another example from our center, although I was not very closely, I was not part of this team, but it's a research that was done from our center as well. It was the e-tracker app. So what was through these English research, what happened was that the government, they wanted to introduce an app where in the app it would be recorded, like, all the immunization records will be there, entered digitally via the vaccinators. And then there would be like an SMS reminder, which would sort of like send out an SMS automatically to the, to the family saying that, tomorrow is immunization day, for your child, please come and, take the vaccine. And what happened was, firstly, the vaccinators were trained on the e-tracker app. And then the vaccinators, when they visited the household, they were collecting details of the children, who needed to be immunized and who are meant for vaccinations. And so they informed mothers about vaccination, that you have to come to the vaccination center, take the vaccine. And the mothers were also informed that the SMS reminder will be sent out a day before the vaccination was due. So when mothers came to the vaccination centers, the vaccinators collected their details and put those details into the app, and at the same time also manually put it in the register. And then for the next vaccination days that were due, SMS reminders were sent out one day prior to the vaccination. So what the implementation research found, that the vaccinators who were older in age, also they were having technological difficulties. They were not, because the tabs were provided and there was an app, they were facing a lot of difficulties to navigate through the app, which was a big reason why they lost interest, and they didn't want to enter data digitally as much as they did on the register. So as an adaptation, what happened was the older vaccinators, the older vaccinators, they were paired with younger ones. And through this pairing up, they learned from the younger ones, which sort of gave them motivation. And over time, they became used to the app. And they were, more willing to enter those details digitally. So this is just a picture from that project. You can see the vaccinating cards and the manual register and the tab. Okay, so what are some of the key concepts that we come across when we talk about adaptation? So one is treatment modification. If you look at the word modification, it's basically like a broad concept that encompasses any adaptations or any changes made to intervention, whether it is deliberately, whether it's proactively or not, in reaction to any challenges that comes when you're implementing modification. Whereas adaptation, which I've already defined earlier, is a process of thoughtful and deliberate alteration to the design or the delivery of an intervention. And what is different from modification is that in case of adaptation, you usually have a plan to monitor the adaptations, what you're adapting, how you're adapting, and what is that adaptation doing? Is it leading to a certain outcome? Then there is also like a fidelity consistent modification that you would come across in literature. So which means that, fidelity consistent, fidelity means that you are adhering to the protocol. You are implementing the way it's meant to be implemented. So when you're making modification, you're not making modification to the core elements, for example. So in that case, it's called fidelity consistent. You're still maintaining the fidelity while you're making those changes. So contrarily, fidelity inconsistent is where you're making also changes to the core elements, or you're like reducing or precluding the delivery of treatment. So these are just some of the concepts that you would come across when you're reading about adaptations in the literature. So this figure just gives you an idea that modification is more of a broad umbrella, and in that you have adaptations and fidelity consistent modification and fidelity inconsistent modification. So as you can see inside the circles, this gives you some examples. Fidelity consistent is when you're tailoring. So maybe you're just changing the duration of that intervention, or maybe you're just adding some module, but you're not really making the bigger change to the element. Similarly, in case of inconsistent modification, you're maybe removing some elements. You're like drifting away from the protocol. Oftentimes, fidelity can be also used as a strategy to address barriers. So, for example, when you know that there's a certain barrier and you know how the barrier may be overcome, and if you are implementing the way that the study is designed to be, then know that it could be used to address the barrier. So fidelity refers to the degree to which an intervention is implemented without compromising the core components, which is essential for its effectiveness. What is interesting about adaptation is, although I mean, there is sort of like a debate going on between fidelity and adaptations, because if on the one hand you're saying that you're supposed to maintain fidelity, stick to what you're supposed to do, not make any changes, but then you know that you need to make changes in order to improve the delivery or improve the outcome. You know those changes are important. So what do you do? Do you still want to maintain the fidelity without making the changes, or do you still go for the changes? So this is where Durlak and colleagues, they really said that there must be a balance between fidelity and adaptation. So whenever you're making changes, you're making sure that those core elements are not really changed, and that there is a reason why you're adapting, and that there is a certain framework or certain guidance towards like what you're doing, and ultimately like you keep a track of what are those changes doing to that implementation outcome. So this diagram just gives you some factors that can really influence our fidelity. I think coming again back into the context and the socio-ecological model that I spoke about in the beginning, there could be some implementers, characteristics. For example, if an implementer themselves, they have a certain attitude towards the health service, maybe they won't be delivering those services because they have a certain perception about its outcome. Maybe they don't, maybe they did not accept that that certain strategy can lead to that certain outcome, or maybe it could be to do with their knowledge about the certain things, could be about their experiences or the trainings they have had. There could be also factors related to intervention. For example, whether the intervention is flexible, can you really make changes, what are the components in that. There could be also be factors related to the setting of the community. For example, what is the budget, what kind of logistic support do you have, and does that really fit within the organizational mission, for example. There could also be some population related factors, for example, maybe certain gender, certain demographics, could be also, health, maybe literacy could be one issues, could be the health access could be one thing that could also kind of influence, for example. And keeping that in mind, it could also, all these factors could influence the fidelity. For example, it can influence the adherence to the intervention. It can also influence to what extent they're being exposed, the quality of delivery, whether they're responding to that intervention. And ultimately, all of this really has an effect on whether the intervention is effective or not. And then, like you can see, the last box is where the adaptation also comes in. You're making adaptation to what? Are you making adaptation to the population, to the outcome, to the setting? And how does that, again, play with fidelity and ultimately the implementation effectiveness? And then, obviously, there's broad key player, which is the social, political, and environmental influences that can also affect how strategies are being implemented. So this figure just gives you an idea about when we're talking about adapting public health intervention, what are the steps that we can follow. So you start with assessing the community, where you are going to implement that, who is the target population, what is the social culture factors there, what are some of the possible barriers, what are some of the practices that are going on in that. So you assess the community. And then you also, the next thing is also to understand what kind of intervention you're, going to provide to whom. And then you select which intervention, could be, useful for that community, for example. Then you consult with experts who are knowledgeable in that area. What is their take on this intervention, whether they think the intervention could work, what are maybe some of the barriers that could really happen. Then you also consult with stakeholders, stakeholders from the community where maybe the intervention is going to be implemented. what are their thoughts and what are their perception, ultimately, if it's rolled out or if it's implemented, will there be buy-in? Will it be acceptable to the community or not? Then based on the consultation with experts and stakeholders, you can adapt the intervention, before implementing it. Then you train staff who is going to, implement that intervention. Then you test whether that adaptation, is really leaning to the outcome that you are hoping, and then you implement the strategy, and ultimately there's evaluation of, whether that outcome is happening as the way you expected, because of those adaptations of how you previously thought you would implement, and later on after consultation, what changes you made and whether those changes are actually leading to an improved outcome or not. So there are two types of adaptations when we talk about. So one is planned. So you kind of decide beforehand what changes you're going to make before you are implementing that intervention. And some adaptations are reactive. So like you are not expecting them, those were unexpected. You go to the community, you intervene, and during implementation, you have certain challenges, coming up, and then you react to those challenges, you make those changes. So those are called responsive adaptations or unplanned adaptations. So there are a couple of frameworks in the literature that really gives us a guidance about adaptations, or how do we report adaptations, for example, or how do we think about adaptations? What are some of the decisions points that can exist when we're thinking about adaptation? So there are three framework and models that I'm going to talk about a bit. So the first is the IDEA model, which is the iterative decision-making for evaluation of adaptation. So basically, this model or framework it's more about focuses on decision-making. There are certain questions, for example, in relation to those frameworks, that you can ask when you're thinking about that, when you're thinking about adaptations. So for example, whether there are data that indicate that adaptation is needed. Do we have data? Do we know what core elements are of that intervention? Do we know about the time frame? Whether it is possible to include like a pilot study, with the proposed adaptations, for example. And to what extent do we think that those adaptations may be, successful in, making the intervention successful? And in case there is not enough buy-in, do you think it's going to be acceptable to the stakeholders? So these are some of the guiding questions that this framework has, which we can use to think and define our adaptations and plan our adaptations ahead. So that's just a very quick snapshot of what this framework really offers. Then the other framework is the MADI framework, which is the model for adaptation design and impact. So basically what this framework does, it offers like a systematic, assessment of intended and unintended impact on outcomes. So MADI framework actually borrows from a couple of other frameworks, but mostly it borrows from the FRAME framework, which I'm going to talk about in a bit. And I'm also going to show you what MADI framework is about. So basically, how it differs from the FRAME framework is in a bit, I can tell you, once I introduce the FRAME framework. So what MADI does is maybe I'll just go to the framework, yeah. Sorry about the picture. I know the writing may not be very clear, but the MADI framework has certain domains. So for example, if you are thinking about adaptations, so what are the characteristics of that? So in the first domain is about adaptation characteristics. And underneath that, if you can see, we think about what is being modified, what kind of adaptation is being made, who's making the decisions, or who's going to make that adaptation, and for whom is that adaptation made, and when is that adaptation occur. So this is under the first domain. The second domain of the MADI framework is, for example, what could be some of the mediating factors or the moderating factors of that adaptation. So for example, potential mediator could be, is the adaptation consistent with the core elements of that implementation or core function, for example. Then also it brings in like, what could be some potential moderators, for example, what is that reason for adaptations, and are adaptations like proactive choices or not. Then there is another third domain of this framework is, what are the implementation outcomes or the intervention outcomes, what are the intended and unintended. So basically these frameworks really helps us to assess how each of those domain is, how domain 1 and domain 2 ultimately affects domain 3, which is the implementation and intervention outcomes. And ultimately it helps us to understand the impact of the intervention. The third framework is the FRAME framework, which is framework for reporting adaptations and modifications. So this is just a snapshot of the framework. Framework is. So basically, it just has some components. This framework is quite popular, I would say, given the vast amount of research that have used this framework. It helps us to understand about adaptations and how, if an intervention has some adaptations, how can we report? So some of the components of this framework is like we report when the modification was made, how it was made, whether it was planned or unplanned, who determined that the modification should be made. So who is the key player? Because whoever is the key player would ultimately have an effect on if it's being offered widespread. Who is that? Is it like a certain key player, like a certain policymaker? What is being modified? We report it. At what level of delivery is the modification made? Is it within the bigger group or is it within the subgroup, for example? What is the type or nature of the context or content level modification? So is a modification more like a content level? Are you adding like a new component to the training manual, for example? Or are you, making some changes to the context? And then you also report to what extent the modification is fidelity consistent, for example. Are the core elements still intact or not? And lastly, also, it's important that when we use this framework, we also report what are the reasons for modification, why the modifications was needed, and what is the goal of the modification? Is it to improve fit, adapt to a different culture, to reduce cost? So just mentioning that. And also, what are some of the contextual factors that influence that decision? So if you look at the framework, some of the reasons could be like a socio-political reasons, could be organization, could be provider related, could be recipient. So you can see some of those common boxes within that MADI framework. Like I said, it was borrowed from many of that MADI components were borrowed from this framework. So this framework just gives us a very concise but comprehensive take on adaptations and how do we report that. So I think this is my last slide. So this is just giving like a snapshot, like a summary of what I've just said. When you're thinking about adaptations, the adaptations come from certain identification of certain barriers and facilitators, right? So you articulate the goal for adaptation, like you understand the rationale, why you're adapting, and then you assess in the community, like who is how is that adaptation is going to play out, who is the target population, and what is that change, what are those changes going to lead to? And then you also decide like what needs to be adapted. Is it the intervention structure? Is it the content? Is it the way it's going to be delivered? Is it the target population? And then you're adapting the intervention through like, how you're delivering that, so just like a iterative circle. Yeah. And I think that's it. I'm happy to take questions or hear from your experience, actually, if you have done, like do you see some of the familiarities, or have you used this framework, or what are some of the challenges maybe you've faced, or anything would be appreciated. Thank you so much for listening.
Great, thank you, Mritika. Thank you so much for sharing today about adaptation. I think it's particularly interesting to be thinking about those adaptations that you can make that are that's where you're maintaining fidelity, and then those other ones where you might not be. And maybe some of the cases where it could call for example, adaptations that aren't necessarily where you're not necessarily staying within the fidelity to the original intervention, but why it might be needed. Do you have any specific examples or experience with those types of adaptations? And I'll ask others to please prepare. If you have questions, please raise your hand or type them in the chat so we can get to everyone. And Ritika, your video's off just in case you didn't know.
Oh, oh yeah, I wasn't aware of that. Thank you.
Yeah. Yeah. Yeah, so the question to you is, can you think of any examples of times where you really need to do adaptations where you are losing fidelity to the original protocol, and what might be good reasons for that?
In my experience, I actually do not, because what I did was more of an research. So it was the implementers that were kind of, making those changes. So for example, the adaptations that I talked about, those were already made. And we asked like why they made those adaptations and what are the reasons they had taken those decisions. And there also we assessed the fidelity and we saw, whether that adaptation is it's for the good or not. For example, whether that adaptation has led to more women coming to the facility, for example. So yes. So again, I think just going back, just finding that balance is probably not easy, but at the same time, I think at the end, in my experience, I feel that in the end, what matters is, that rationale for adaptation. And ultimately, are you really achieving that outcome that you wanted to through your intervention?
That's
And
great.
like
Thanks,
at what
Ritika.
cost? Yeah, thank you.
Yeah, and I think what you talked about today maps very nicely with what Dr. Piyusha Majumdar talked about last week in terms of context, right? Really needing to make adaptations based on new context and the contextual information that we have, right? Measurements of barriers and facilitators, right? The information that we might know about a given population, place, or outcome of interest. I see, Gloria, you've raised your hand. Please feel free to jump in.
Can you hear me?
Yes.
Okay, excellent presentation. Thank you very much. So I just have like a doubt about maybe the terminology, and it's specifically related with what we are going to change, or the implementation strategy, or we can adapt also the intervention. That is one question, because sometimes we use the terminology of intervention to define implementation strategies also. So that is one question that I would like to be like more clear in that sense. What is adaptable? Because as my understanding, we want to keep as close as possible the core elements of the intervention, and the adaptable features will be the elements of the implementation strategy. Did you hear me?
Yes,
Yeah.
I did.
Okay.
Yeah.
Okay.
Thank you. Thank you, Gloria, for that question. I think it just brings us back to that, that first slide that I talked about. It's really important to understand the differences between intervention and implementation strategy. So intervention in, for example, the example that I showed is the transport system, which is meant to, bring women to the facilities, for example, because ultimately the outcome is you want to make sure that the women are giving birth at the facilities and not at their home, which could be very complex and sometimes fatal, for mother and and the child. So then you're not really making changes to the intervention, because the intervention is there. I mean, that's what your plan is. Your intervention is that you are giving that car. But how you're bringing the mother to the facility, you are making changes to the process itself, the implementation strategies. So the adaptation is always made to the implementation strategies, not the intervention. So ultimately, if you're changing the intervention, you're not providing a car, let's say you're providing something else, then that's a different intervention. I don't know if my other colleagues would agree with me or maybe has something to add to this. I don't know, Gloria, did that make sense? Or maybe you have some thoughts?
No, I have some thoughts about it because maybe we stick too much in the program that we are developing in Colombia, in the guidelines of the World Health Organization. I'm going to speak an experience that I have with my student leader, who I think she is here. We use the ELMI plans, which is an intervention very well defined and published in Colombia. And we try to understand what were the barriers. Of course, we use the Cephir, and then we use the ERIC matching, the Cephir ERIC matching tool to understand the implementation strategies that will address the barriers. And of course, we find like education, well, several things that they need to be implemented or changed or used, in order to get the best or improve the adoption of the coverage with the intervention, which is to control the transmission of mother to child or several transmissible, sexual transmissible diseases. So basically, now we have a question if those implementation strategies that we found actually are going to respond, to the barriers that we found in that context. That's one thing. And again, I think we have to try them or look for other models in order to understand better what we have found. But the other thing is, if the prescription or how it is prescribed, EDMI Plus in Colombia, that actually is very complex, could be changed without changing the components that it has to be in place in order to get the benefits or the efficacy. So to speak, the number of times that I have been tested the women, before pregnancy, during pregnancy, and after pregnancy, and the medications that they, for example, mother and children have to receive in case that they appear positive in this test. So those are the questions that I think I understand. Those things cannot be changed. We have to keep them as very close to the guideline. However, for example, if we are going to educate, there will be several ways that we could educate mothers or healthcare providers, and that's the thing that we can change. And actually, in the specification that you did, the doses, the numbers, the target population can be changed, and that will be the change that we do to the implementation strategy specifically. So there is I would like you to discuss about it. If that vision or that way to think, we have to be more flexible, so to speak, or not. How we leverage that.
Yeah, I see your point. Yeah. But Anna, what do you think, or maybe any of our colleagues can really add to this?
Yeah, thanks, Pratika. I mean, I'm not an expert in adaptation, so
Yeah.
I'm really looking to you to speak to this. I mean, my understanding is that, right, there are trials that can be designed specifically around adaptation so that you can understand all of the different components that you can adapt, regardless of what they are, in order to ensure that it's working the best for the population that you're working with. So maybe Gloria, I'm not so clear on what the distinction is between what you're trying to say you can or cannot adapt.
I mean, I'm clear in the sense that the core elements of the intervention that are the ones who obtain the efficacy of the treatment or whatever could be changed a lot and lose the efficacy. That is the need for implementation research. That we are now sometimes using the intervention as we think it should be, and not as it has, to be used. So to speak, the number of times that I give a vaccine, or the period of time that I have to give the vaccine, because that was how it was demonstrated that it works during the intervention trial. And then how we change that, or if it can be changed, it has to be demonstrated in an efficacy trial and not in an implementation trial. But besides the implementation strategies, they can be changed because they are not going to change the core elements of the intervention. So that's what my understanding is. So because that's what is happening now, and why that's why many interventions do not work in the daily routine services, because we have changed the core elements of the intervention. So to speak, we have to screen, or we have to screen only women who are pregnant, so to speak, at this, population. And we changed because of the difficulties to reach the population, to screen, just once at a time during her life, not as frequently as the guideline says. So that's the change that we do. And by doing that, we are going to decrease the effectiveness of the intervention, because we need to screen several times in order to find them when they are positive. So to speak, is my example. So that is my reasoning behind it.
So you have
But you can
changed the
change
implement. Yeah.
Yeah,
You
can
have
change
changed
the
the implementation
implementation.
strategy.
Exactly, but you
So
have to be very
we
careful
just
in not
have,
changing the core elements of the intervention.
yeah, I think this has been a helpful discussion. We just have 2 minutes left, so I'd like to offer an opportunity if there's anyone else with a question or a comment. Ritika did ask if others had experiences with adaptation that they'd like to share. I
see a
see, Ritika, there's
question.
one question in the chat.
Yeah.
Yeah, maybe why don't you try to tackle that question, and then we can take a photo before we sign off for today.
Thanks. So do you think that Edison has written, do you think that in the implementation of an intervention, there are certain components that cannot be adapted? For example, Dennis spoke of essential elements in Carroll's framework modified that we can't modify. I think again, going back to the discussion, what if you already identify what are some of the core elements of that intervention, without which the intervention is pretty much nothing. It's not going to be effective. For example, you are bringing in like you want to introduce, let's say, like an app, but you haven't really trained people how to use that app, for example. So if you already identify some of the core elements, it's like there isn't really, I mean, it's very difficult to say that it cannot be adapted, but it depends on, I think going back to what I've said, depends on at what level or what is being changed. Are you changing the context, for example, doing a different location, or are you, taking, different people, or, are you taking different age? So whatever, I think it just comes down to, is there a need for adaptation? Why you're making that, and how is it going to affect the implementation of the intervention? And I think most importantly, keeping in mind how is whatever change I'm making, how is that going to affect ultimately the outcome of that intervention? Am I expecting better results because of that modification? And is my rationale to modify driven by data? For example, I think Gloria was just speaking that they made all those changes, and I'm sure those were data-driven decisions as well, right? Because you have experiences in the field, like you see that it's not working. So let's say that, going back to my example, they were writing on the walls of the houses. Maybe they felt that, what if the mothers couldn't read the numbers because the literacy is not very high? What if they lost the card? So maybe they found adaptation. Okay, I'm going to write the number on the wall, but is it really changing my intervention? It is not. It is just bringing in people, but via a different mechanism. So is my intervention changing? No, I'm still want the mothers to use the vehicle. I still want them to come to the facility. So what am I exactly doing differently now? So I think adaptation should be, thought from that perspective. Yeah.
Yeah,
I don't
thanks,
know if
Ritika.
that
And I
was
think it
helpful.
speaks
Yeah.
to your earlier point about how adaptation is systematic. And so that means that you need to be able to clearly identify every component of your intervention, every component of implementation, in order to clearly define your strategy. And this is, there's guidelines from Proctor et al. On how to do this, how to really define your implementation strategy so that when you're making adaptations, you know exactly what you're adapting. With that, I'd like to give a big thank you to Mritika for providing this
Thanks,
lecture and for this discussion at the end. I know IR Connect is asking us to take a photo, so if everyone online could just put their video on for just a moment, a quick moment, so that we can take a photograph here at the very end. And then as you log off, you will have a web browser pop up with asking you to complete an evaluation for today. It's very, very short. Please do take a quick moment to do that as you log off. Okay, video's on if you can, and Nidhi, over to you to take our photo. I'll have you lead it, please. Do you have any instructions for us?
Yeah, so maybe I'll say 1, 2, and 3.
Okay.
Okay, 1, 2, and 3. 1. Okay, 1 is done. One more
Okay.
photo. Let me.
Just one more, quickly, please.
Yeah. Okay, one more. Yes, done. Thank you.
Thank you so much.
Thanks, everyone. We'll
Thank
see
you,
you next week.
everyone. Thanks, Anna.
Thank you so
Bye.
much. Bye.
Thank you. Thank you.
Thank you.